Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
Welcome to EHA Unplugged, the official podcast channel of the European Hematology Association. My name is Sarah de Vlieger and I'm the Head of Education at EHA. I'm here today with Sarah Tettamanti. Sarah, could you please introduce yourself?
Yes. Hello, everybody. I'm Sarah Tettamanti and I work in Monza at Fondazione Tettamanti Research Centre in Italy. And we are interested in immunotherapeutic strategies for acute leukemia.
Your research focuses on how to use the immune system to fight AML. We're here at the CAR-T meeting in Valencia. Are we any further in that regard, getting CAR-T cells to work in AML?
Yes, it is a really challenging field because CAR-T cells have achieved a really good success for acute leukemias. While for AML we are still in an infant phase, I would say, because we are trying to move from the experimental clinical phases to the approved commercial products, but we still need to be good in balancing the efficacy profile and the safety profile of this product. So AML is another a really different disease as compared to ALL. And so we are learning a lot from the clinic to go back to the lab and try to improve our CAR-T cells, because we know that we need to improve them in order to make them more persistent and more efficient, but at the same time to be safe, because of course we have some challenges and limitations in AML. We know from the biology of the cells of the tumor microenvironment that we have to deal with this immune suppressive tumor microenvironment. We have to deal with the blasts. The AML blasts are really able to try to make T cells dysfunctional. And also we do need to care about the selection of the antigen, because for AML we do not have a proper specific leukemia specific antigen. So in my career I had to deal with the balance between being efficient but at the same time being safe. So because we are sharing these antigens also with the normal counterpart, and the side effects could be really detrimental in our case. For the BALL, you have B-cell aplasia, you can cope with the immunoglobulin infusions, but with AML, of course, you could have myelotoxicity, and this will be detrimental for patients. So this is the balance that we need to, to think about and to envisage more smarter CAR-T cells. So actually the CAR-T field has developed a lot. So we started from first generation CAR-T cells, then second, third, and now fourth generation CAR-T cells. I would say that this is the future. So try to combine the targeting of the leukemic cells, but also try to target also the tumor microenvironment. So to be able to make CAR-T cells to eliminate the cells and to be able to make their activity inside the body. And another issue is trying to make these cells working, and also probably we need also to combine the CAR-T cells with other immunotherapeutic strategies such as checkpoint inhibitors in AML. They are not so successful because there are studies with anti-PD-1, anti-CTLA-4, but they are not so successful at the moment. Anti-TN3 is kind of emerging. TN3 is an immune checkpoint we are also interested in because it is also overexpressed by leukemic stem cells. So you can use both for the targeting of leukemia stem cells and also to immune modulate the tumor microenvironment. So this is a really interesting target. And so checkpoint inhibitors, we are a little bit moving fast also in this field, and the combination of all these strategies could be something interesting. And also I would say CAR-T cells are living drugs and they act at the surface, okay? Mm-hmm. So they target a surface antigen. Yeah. But we know a lot about the molecular therapy. So probably also we can play with the surface target with CAR-T cells and also molecular targeting with, the small drugs that we now know that they are really specific for some altered pathways that are inside of the cell. So I would say that this can be something that we can think about in the future.
Which of these strategies do you have the most hope for?
Among these,
Yeah.
I mean, this combination, because in my opinion, if we are, I would like to avoid the high chemotherapy to patients. So I would like to really pursue the targeted therapies, meaning CAR T cells, monoclonal antibodies, bispecifics, and molecular targets, targeting drugs. Okay, so in the future, my dream is to have like a protocol in which you can really make low regimen chemotherapy and to make patients, being healthier in their path during the disease treatment. And also the CAR T cells, of course, if they have a good balance with safety and efficacy, can be something interesting. And also nowadays we know that, for example, CAR T cells are used as a bridge maybe to other therapies, but at least you know that in that treatment, if you are safer than as compared to chemotherapy, the patient is healthier, so it can continue his disease treatment in another way. So the quality of your path, I think it matters, and immunotherapy can also help in this way. Of course, we all hope to cure the disease and to treat all the diseases, but at least also offering a good quality of life during the treatment of patients it matters.
How far do you think we are off this sort of ideal in the clinic?
I do see that we really did a lot in the last decade. Because if I think about me, 10 years ago, I was during my PhD, and CAR T cells were only something that, really good biologists were like studying. And then in 2012, of course, we had this breakthrough of these CAR T cells in the clinic, and we started to really think about this option that could be a really valid option. So in a decade, of course, everything happened, and CAR T cells were also started to be useful also for AML, also for solid tumors. So I think that we are really making the difference in the treatment. Immunotherapy is another arm of the advanced medicine, and we still need to understand a lot, especially in the solid tumor context and in this kind of immune suppressive diseases, also in the context of hematology or oncohematology like AML or CLL, for example, is another tough disease to treat with CAR T. I mean, we don't have the same rates of CR as compared to the BALL, even with CD19, the classical CD19 CAR T cells. So I think that we are in a moment in which we are really learning a lot from the trials, and we also have the technologies to understand what happens inside our body and also inside our experimental setup. I mean, we started doing, basic cytotoxicity assays. I remember during my PhD, I was using chromium assays, to see the cytotoxic activity, and now we have real-time devices that can measure how the cells are making, their anti-tumor activity. You can follow them for weeks and months, and you can image them. We can go inside the cells. We can study the single-cell RNA and what happens, and also from the patient. So immunomonitoring and taking the cells out and understand them in a better way. So I think we have the right tool to make another step and to put a step forward in the treatment of tumor.
We've primarily been talking about CAR T cells. Is there any role for any of the other CAR cells, the natural killer cells, for example, within AML?
Yes, right. I mean, we, as maybe you heard from my talk, we do use these effectors that are called cytokine-induced killer cells. They are T lymphocytes, but we know that they have some functional properties related also to the NK part. NK cells are really good, especially for AML. In clinical trials, only using NK cells, there was a really good success result. And I think that NK cells are really useful. Of course, they are safe, and you can redirect them with a CAR. And in the AML, I'm really curious to know about the upcoming trial that will start in this sense in the next future. And so also playing with the effectors is another important aspect. So we know about gamma delta T cells, classical T cells, our CK and natural killer cells, of course, because if you think about the CAR, okay, it is an artificial receptor that helps you to be more specific and to, but at the end you are using a T cell, so you know that you need also a fit T cell. Mm-hmm. So the effectors are a good point, but also their fitness. So autologous source versus allogenic source, this is another important point. Okay. Especially in AML, the first wave of clinical trials in AML were all made from autologous source. And now we know from the biology of the disease that these cells have already seen the AML cells, and so they are already dysfunctional. So that's why we had this low persistence of the first clinical trials with AML. I mean, this is my opinion. I think that also using autologous source, it's okay, it's safe. It's something that of course we had to try. But now we need to move to more fit cells as well.
Okay, so I mean, there's a lot of discussion about moving CAR therapy towards an off-the-shelf product. Yeah. Do you think that could ever be a reality?
So, okay, we are working on that. We are trying to derive CAR-CK cells from the cord blood source. And I think this is a useful way to derive allo CAR-CK cells. In our case, we are not thinking about removing the TCR because we have already data that CK cells are kind of safe in terms of GVHD. We have to know if they will persist in the allo setting or aplo setting. This is something that we are going to investigate in the next future. But still, I think that the off-the-shelf is a really good option because, of course, we are dealing with highly proliferative disease. So, I mean, sometimes you don't have the time to treat the patients. So you need something that is ready to use. And I think this is a useful source, also the cord blood or other sources to make allo off the shelf. Thinking about elderly patients, for example, in AML, maybe they are not fit for the transplant, and so the cord blood can be a third-party source to make the off-the-shelf. So these are all the thoughts that we have in mind, thinking about off-the-shelf in AML, particularly in AML. And also, this is a really aggressive disease, so we need a source to be used immediately. And also, you can also organize the production by making a banking, and then you have the time to do the matching, and then you have the cells ready to go into the patients. So, yes.
Sounds like there's a lot of exciting things happening in AML.
Yes.
Is there anything else that we haven't discussed today that you'd like to mention or?
Probably we can discuss about the clinical trial design. I think that we need really to think about how to design the clinical studies. And also another topic that we didn't discuss about is the affordability of these therapies. So in our place we are using non-viral system. It's 1 log less the price of using non-viral versus viral. And also in our case we can treat HIV positive patients in potentially because we don't have the problem. I mean, we are using non-viral CAR T cells. Yeah. And so, for example, in the upcoming trial for non-Hodgkin lymphoma patients, we will enroll also HIV patients. And for the low-income countries, we know that there are lots of HIV patients. And so this can be something that in the future can help in making CAR T cells more affordable, more accessible. So this is another important point that we have to think about. Maybe not only the viral, but only maybe streamlining the process, the manufacturing process. If you do the cells in 2 days, it's different the price if you do the cells in 2 weeks, okay? So shortening the culture will be, it seems to be good also for the T cells, but also from the cost point of view probably. So this is something that we have to take in mind also from the preclinical point of view.
It's fantastic. Thank you so much for the insightful conversation.
Thank you.
And thank you for being here. And thank you to our listeners for tuning into this episode of EHA Unplugged.